Hello, everyone. My name is Alyssa Lambrecht, and I am a medical student at Ohio University Heritage College of Osteopathic Medicine and a third year rotating in Toledo, Ohio. In this video, we're going to talk a little bit about substance use in the physician population, how to recognize signs and symptoms of colleagues or yourself who may be struggling with addiction, and how to find support and resources to get better so that we can serve our patients and keep ourselves as healthy as possible. So first, I'm just going to have our panelists introduce themselves today. Dr. Meyer, would you like to go first?
Sure, I'm Chris Meyer. I am in Athens, Ohio, and I practice addiction medicine. I am a graduate of Des Moines University. I eventually ended up in an internal medicine residency at Michigan State and then a GI fellowship at Yale, and practiced in gastroenterology for a long time. Was eventually a chief executive officer of a healthcare system and resigned to get away from that. And then I did a fellowship in addiction medicine at the University of Florida. I have been active in treating physicians with substance use disorders at the Talbot Center in Atlanta, Georgia, and at the University of Florida Recovery Center. More importantly, perhaps, I have a lived history of addiction and have been in recovery for 25 years.
Go ahead, Dr. Kapaska.
Okay, I'm Dave Kapaska. I'm a DO from Des Moines University also. I did my residency in family practice, practiced in rural Iowa and then in Des Moines for many years, and eventually became the chief medical officer in McKinnon Hospital in Sioux Falls, South Dakota, followed by CEO there for the past 7 years, and then retired 6 years ago. So had plenty of opportunity to watch the addictive challenges, behavioral challenges of physicians as they go through their pressure-packed careers.
All right, thank you. And I think one of the main purposes of this discussion today is just to help normalize that physicians, like general members of the population, all have similar struggles with mental health, substance use, and that it's nothing to be ashamed of. We just want to make sure that we're helping support each other and ourselves so that we're providing safe patient care, and then also just helping get to a better recovery standpoint. And there's different statistics that at least I had read, and if you two know of any other ones, feel free to share, but that about 15% of physicians suffer from substance use disorder. And according to the Ohio Physicians Health Program website, that 1 in 4 healthcare providers were seeking support, whether for just a mental health disorder or addiction medicine. But following the COVID pandemic, a lot of professionals were seeking help. And one of the interesting things I thought about this website was that it did provide help and support for either mental health disorders, general burnout concerns, as well as substance use disorder. So maybe each of you could talk a little bit about maybe a time in your career where you were feeling some of the pressures, or when you noticed colleagues were, and what sort of symptoms or signs they were showing to either lead you to think that they had some sort of addiction or substance use issue. And Dr. Meyer, I'll hand it to you first.
Well, the figure is right. It's about 15%, which mirrors the prevalence of addiction in the general population. I guess I'll start with my own personal history and try and be brief. Well, I'll kind of meld the two. I'm a firm believer that substance use disorders represent a chronic disease, and not unlike other chronic diseases, like diabetes mellitus or asthma. But there is a component of a hijacked brain that leads to impaired executive function, that leads people to make bad decisions. So I came from a long family history of people who struggled with substance use disorders, and had that in my background. I began smoking tobacco at about age 20, and became a binge drinker while at medical school in Des Moines. But I only drank on weekends. And I only drank 1/5 on Friday and 1/5 on Saturday. So I was sure I had no problem with alcohol, although my roommate suggested that I might have had. In my internal medicine residency, after growing weary of hangovers, I moved towards marijuana, and became a daily consumer of marijuana. And I don't think I necessarily did that to deal with stress or anxiety or things of that nature. I just liked getting high, and everybody was getting high. So why not? But it led to my using it every day, and I was always under the influence. I rationalized and denied and defended in the discussions I had with myself as to whether or not it represented a problem. And of course it did. But I did my job, and I was high functioning, and I progressed through my career impaired. And then when I came to Athens, Ohio, I kind of had been separated from my supplies of other drugs like marijuana and cocaine, and I started drinking again. But I was much less able to control the drinking in terms of the obvious impact on my performance than I was other substances. And I eventually was arrested one night, and at the time I was serving as an associate dean, which doesn't go over very well with university presidents. And an intervention happened, and I was asked to go to a rehab program for an evaluation for 48 hours to determine if I did have a problem with alcohol and other substances or not, which I did, because by that time I'd been reported to the medical board for having had a DUI. Yeah, and they released me 6 months later after signing a consent agreement with the PHP program, Physician Health Program in Ohio, for 5 years, in which I would agree to ongoing counseling and urine drug screen monitoring and participation in mutual support groups, which I did. Since that time, I've been a very, very active player in the recovery community in my county and town. I continued to attend 12-step meetings. I gravitated eventually toward the field in which I practice now, which is addiction medicine. I started a 12-step-based recovery residence about 17 years ago. And we take care of about a dozen men at a time, trying to help them find recovery. And I eventually retrained at the University of Florida in addiction medicine, and worked there as well at the recovery center, dealing with predominantly physicians who were admitted with substance use disorders. That's my lived experience. And if I could just briefly finish with the sorts of red flags that identify someone who's practicing medicine with a substance use disorder, are things like being absent from work frequently and missing appointments, rounding on patients at odd times, a disorganized approach to patient care, multiple prescriptions to other folks, inaccessibility to staff and patients. And these are the sorts of things that can identify a physician who might have a substance use disorder. And I'll pause there and let Dr. Kapaska take over.
Well, thanks, Dr. Meyer. I appreciate it. I appreciated your honesty and frankness about your own history, because I think it really solidifies what we're talking about today. And that being my own history, I don't have a history. I had asthma pretty badly as a child. And so smoking was never an option for me personally. Just from that, I know what not being able to breathe is like. So, and second, I'm allergic to something in beer, and I wheeze like a banshee when I drink beer. So those two things were kind of off the list for me fairly early. But I do remember one night in my first practice in a small town, two of us, 36 hours on and 12 off, unless something happened in the 12 hours off, and you just work constantly. I'd been up for about 3 days in a row, and I was walking, taking care of a patient in the hospital in the middle of the night. I was walking back to my house, which the clinic was between the hospital and my house. That was my world, 1 block. So, but it was raining terribly hard, and I was walking along, and the person I had replaced had a substance disorder, and so I was walking along, and I looked over at the clinic in my return home in pure exhaustion, and I finally understood what must have gone on in his mind. And it certainly crossed my mind that was an option, because we had plenty of substances at the clinic if I so choose. But I think in this, in your story, which is typical of many, that ability to perform, under some semblance of substance use is amazing. And I think that oftentimes we overlook, or as you said, your colleagues would make comments, and but you keep functioning, and our ability to see that in the workplace sometimes is very difficult, because you choose weekends or days off or whatever it might be. And I'm not picking on you. You're just a perfect example of what I've seen, that it's very late oftentimes in the clinical realm that we recognize challenges, and knowing full well that a family at home has probably suffered deeply, let alone the person that's addicted suffering in their own right, but people at home, people in that may be up close in the workplace, that get our outflows of negative energy perhaps, and such, are not as recognizable to supervisory physicians or CEOs or medical directors or whatever until late. And I think that's one of the things for us, that when we suspect that one of our colleagues is struggling, that number one, we want to help them. And number two, knowing that there are people in the background that are probably suffering already because of this situation. So it's not just a single person or a single entity problem, but a multitude of challenges, and has inspired me over the years to be more aggressive is the wrong word, but more cognizant that something need be done or addressed at least, and move from there.
Yes, thank you both for sharing. And I think that does bring up like a good point, that sometimes these, as students, especially in residents, are still learning how to adjust to intern life and maybe new roles, that sometimes the symptoms may be overlapping, of like a little disorganized, not really knowing what's going on, kind of overwhelmed feelings. But maybe, that's kind of where it starts too, is when you're difficult and high pressure situations day after day, and having access to medications, it presents a problem that I feel like we all need to be cognizant of. And it can be very uncomfortable to feel like you want to have one of these conversations with someone either you're friends with or a colleague. So do you have any advice for students and other physicians of how to bring up these conversations respectfully with having like the best interest of the person in mind? Dr. Meyer, do you want to go first?
You're talking about how to bring up with a physician who might have a problem.
Yes.
Well, it generally doesn't go very well.
Yes.
And efforts to do that, although well-intentioned, generally don't go so well because, like Dave mentioned, clinical performance, a deterioration of clinical performance is almost always the last thing to go. And then, of course, for those of us who have struggled with substance use disorders, one is so invested in defense mechanisms like denial and rationalization that it's awfully difficult for an untrained observer to break through all of that. And those sorts of endeavors usually are fruitless. The reality is that most people in general, and certainly most physicians, never volunteer to receive treatment for a substance use disorder or to be evaluated for one. Because they're too far in denial. It's usually some sort of calamity that leads the physician to come to the attention of a department chair or a medical director, and then a sequence of events is triggered that hopefully leads to an appropriate evaluation and then treatment. Prior to that, I have never witnessed or been part of conversations that bear much fruit.
I would agree, Chris, totally. And I think the pieces that the hinge points, obviously there are hinge points with family and other things, but the hinge point professionally is that license. Privileges also, but certainly your license. And if you lose that, Katie, bar the door. I mean, you're now going to find a job for $40,000 a year and probably not live the same lifestyle that you're used to. And not to put this into economic terms, but so the conversations that I've had to try to get people for an evaluation, at least, has been focused around if we do this the right way and get an evaluation, we can clear the air. You don't have a problem. Or if we have a problem, we can fix it or work on fixing it without putting your license on the line. And that seems to me, I'll lift up the physician health programs that virtually every state has, that typically run by the medical society, or at least organized by the medical society, but blessed by the board and others typically. And I don't know the politics of every state, but and there are programs that you can go into, and if you're successful, and you had mentioned that, Chris, for yourself, if you're successful, your license is not even approached by the board or anything else. The board is happy that you're doing well, as long as you mentioned the 5-year program, as long as you follow the rules and maintain the process and such during that time frame. You can continue to practice and your license is untouched. I had an example of a cardiologist, a wonderful guy who I didn't know had a problem one day right outside my office, I heard a crash right in front of the emergency room. A car had driven right into a parked car, and doesn't he get out? And he's inebriated, and I chatted with him. We did all the things in the ER, got that going, but he got into the program immediately. And because it was somewhat of a binge situation for him, it turned out, and I don't know all of the facts, but he was back at work in 3 weeks under a tight program. And having him back at work was really important for me and for the patients that he cared for, if he was safe. And so he got into that because of these physician health programs, and could practice and continue his life under very tight scrutiny, without, again, putting his profession, his own professional future in danger.
I would jump in and comment that unfortunately there is a bit of a conspiracy of silence within the medical field to protect each other. And that works to the disadvantage of institutions, patients, and those clinicians who have a substance use disorder. The conditions are much better now than they've ever been before because of these physician health programs that are mandated in each state to function in association with the state medical board. But there are signs and symptoms that eventually start to surface for doctors who have a substance use disorder. And for those people who are working with those people who are struggling, be they nurses or other physicians or house staff officers or administrators, the imperative is to try and determine if someone really has a problem or not by reporting that individual to the physician help program in the institution, if there is one, or to the chief medical officer, or to the section head of surgery, and allow them to do the investigation. And once that happens, the process follows out pretty well. And if at the end of the day, the individual in question has been diagnosed with a substance use disorder, then he or she has the option to receive treatment or not. Like Dave mentioned, if he or she chooses not to, then the medical license is in jeopardy. But if one chooses to get help, one will likely have to then sign a consent agreement with the state for monitoring for a period of time, but one goes on practicing. The problem is this conspiracy of silence in which nobody wants to step up and pull the trigger to determine if a specific physician is struggling.
I would definitely agree, Chris, with that. I think the other piece that comes to mind for me, and you had mentioned it briefly, but the symptoms can be varied from anger management into depressive type symptomatology and such that may not lead one to think substances are a part of that at all. And they may or may not be, but the reality is it's disruptive to the environment the physician works in. It's disruptive to their life also, although again, they don't necessarily recognize it. And I think in this whole world of burnout, which has become such a common term the probably last 10 years or so, we just say, well, that's normal, fatigue, all these things. And there have been several times that I encourage people to go for an evaluation, not because of alcohol, but because of behavioral things or anger management, that type of thing, through the same process that we discovered that there were ancillary things going on that and either way, that needs to be, those behaviors need to be solved for whatever the causation is. So I just throw that out as more than just starting with the fact that they're smoking marijuana every day or that type of thing. It can certainly be a broader starting point.
Well, I think this is the key. Whenever aberrant physician behavior is observed, given the ubiquity of substance use disorders in society, the first question that must be asked is, could that aberrant behavior be related to a substance use disorder?
Yes.
And that then triggers a cascade of events that hopefully will lead to the individual getting help.
Yeah, thank you for bringing up all of those points. I think they are all very valid and kind of help paint the picture of why it's so hard to find like help physicians get to that point and maybe identifying. So as we wrap up the discussion today, Doctors for America, we do try to focus on advocacy and what you can do, what we can all do to help create like a better environment for this. And I think one of the things that I kind of learned today and just with this project is that like the way we speak about our patients with substance use, our colleagues are listening, the people around us who may also experience substance use hear what we say behind closed doors. And so kind of changing the way we speak and being cognizant that anyone around us could be experiencing these things is really important to keep in mind. And also just knowing what resources are available to physicians, because before this, I had really not heard of the physicians' health programs. And like you mentioned, Dr. Kapaska, that even a physician with burnout or a resident that you might see struggling, some of these resources are not only for when they maybe develop into a substance use disorder, but kind of catching people before they fall too far down into a hole that they can't help themselves out of. And so just checking in with your peers, whether or not you think it's a substance use disorder or not, just always being there and taking care of our family and healthcare. Do you have any last advice for physicians about this topic, about ways that they can help kind of help this problem and hopefully make it more acceptable to talk about and maybe breaking some of that silence? And Dr. Kapaska, I'll send it to you first.
Well, I think the key thing is that when you sense that something's not right, waiting is not a good option. And we know that the full continuum of behavioral challenges can end up with suicide and such, and doctors certainly fall into that realm too if it goes far enough. And so to ignore or to say, well, I'm sure the CEO will see this sometime and take care of it or whatever, I think is not being a good colleague. And although addressing it is very difficult, there are a multitude of ways to at least start a relative investigation for the safety of your colleague, not for his demise or her demise. So I would just encourage that time is the enemy if you want to put it off or leave it to someone else.
I think about the only things that are more stigmatizing than having substance use disorders are being in the carceral system, jails and prisons, or being a sexual predator. Substance use disorders are just so stigmatizing. And so I don't really have much words of wisdom for someone who wants to get help. But once the problem has been identified, then what the individual, physician or otherwise, has to accept is that, hey, I've got a disease. This is a bona fide, real disease, and there is good treatment for it. But to get that treatment, I must be very, very honest, open, and willing to pursue the sorts of things that are going to get me well. So I think the work really comes once the individual with a substance use disorder surfaces.
Well, thank you both for your time today. I think your stories have been really helpful, and hopefully just bringing up this topic allows other physicians to have this discussion and hopefully get some of the courage to bring up these conversations with their colleagues. So with that, I'll leave resources with the video related to how to get access to physicians' health programs and other resources to learn more about how to help yourself and colleagues. And thank you for listening.